best for last here. On a population basis, I think there's nothing more important than functional bowel disease, and nothing that my patients in clinic ask me more about than complementary and integrative medicine. So we're very pleased to start with Lin Chang to start us off today. Lin is a program director at UCLA and vice chief of GI. Thank you, Lin.
Thanks, Gareth. Thank you for the organizers for inviting me to speak here today. So I decided to try to pick a few topics that I thought were clinically more applicable for you now. And there's, so many IBS types of abstracts, but I picked these three topics. So one is Plecanatide, since that's a newer agent. I thought you were probably very familiar with linaclotide and other constipation treatments, but maybe not as familiar with Plecanatide. So I decided to talk about that topic, IBS with constipation. And I thought something that you would be interested in, or your patients might be interested in, was Kiwifruit in IBS with constipation and chronic idiopathic constipation. And then the question that the lay public is always asking is about fecal microbial transplant for all different GI disorders and also for IBS. So I was going to summarize the abstracts that were emerging data from the DDW. Okay, so this is a table that I made that when I think of taking care of a patient, I think about what I want to target, what physiologic process I'm targeting. Is it GI motility and transit and bowel habits, or am I really thinking more about abdominal pain, visceral hypersensitivity, or more of the psychosocial symptoms? And then I just divided it up, whether it's more of a constipation predominant patient or a diarrhea predominant patient. And you can see that there are some different agents that you could use for different types of symptoms. So I'm going to talk about Plecanatide. So this is FDA approved for chronic idiopathic constipation. Really is just the regulatory term for functional constipation. That means chronic constipation without predominant pain. It's also FDA approved for IBS with constipation. That means that you have pain associated with the constipation. So pain is a predominant symptom. There's only one dose. It's 3 milligrams, and it's given once a day. So that makes it straightforward. So basically, Plecanatide and linaclotide and lubiprostone are peripherally acting agents. This is the lumen of the bowel, and the linaclotide and Plecanatide are guanylate cyclase C agonists, and when they act on this receptor, it increases chloride secretion through our primary chloride channel, which is the CFTR. Lubiprostone works by increasing chloride secretions through the secondary channel, CLC2. So they work mainly peripherally. They're not really absorbed much. So this is the 2 phase 3 trials from Plecanatide in IBS with constipation. I'm not showing you the functional constipation data. This one hasn't been published yet. Oh, it's just recently been published. But you can see this. Actually, I think this is an abstract. I don't think it's been published in full publication. So you can see there's 2 different doses that were tried, Plecanatide 3 milligrams and 6 milligrams, and then placebo. So currently, the regulatory agencies, both in Europe and in the United States, ask for the primary endpoint to be a composite endpoint. And that means you need to have a 30% reduction in abdominal pain in 50% of the weeks. And on those same weeks, you have to have an improvement in complete spontaneous bowel movement. So that not only do you have a spontaneous bowel movement, you have to feel like it's complete. And if you have those both in the same week, 50% of the time, you are considered a responder. And that's what the FDA wants now. They want a responder definition. So what you can see, it's a higher bar to reach now, but you can see that the responder rate for Plecanatide was significantly higher than the responder rate for placebo for both trials. But there really wasn't a difference between the 3 milligram and the 6 milligram, and that's why it was FDA approved at just 3 milligrams. So that's the phase 3 data. So I'm going to show you 2 abstracts that are related to Plecanatide. And this one is on the safety, tolerability, and effectiveness of Plecanatide in IBS with constipation, but more long-term evidence. So these are patients that were stayed on the drug for a longer period of time because they were looking at safety and tolerability and not efficacy. So the aim, as I mentioned, was to assess the long-term safety and tolerability. This is something I think patients are interested in. It's a multi-center long-term open-label study. It included any patient who had been on their previous dose-ranging phase 2 trial or anyone in their phase 3 data, their phase 3 study that I showed you, or they failed screening in a phase 3 trial, or they had never been previously treated with Plecanatide. They were entered in the study. It was up to 53 weeks, so it's 1 year, and they were either on 3 milligrams or 6 milligrams. So you can see here, and not to get caught up in the details, but they had almost 2,500 people screened. This was their safety population, so over 2,000, and a modified intention to treat. So these are patients that they analyzed their data. So I just summarized the results here. If you look, okay, so they didn't use the efficacy endpoint. They used a patient global assessment. So of course, that's a subjective endpoint, but it was symptom relief. Okay, so they had to have at least significantly, you see in the orange, or moderately relieved symptoms. They had a patient global assessment for satisfaction. How satisfied were they with the treatment? And then would they continue the treatment? So what you can see here is about 40 to 50% for each of these endpoints. You see that for significantly relieved or very likely to continue treatment. For the moderate relief, you see about 30%, and then the same percentage for quite likely. So you can see over a 1-year period of time that a fair number of patients continue to have satisfaction and tolerability of the agent. As far as adverse events, 6.7% developed diarrhea. And I know this is an issue with guanylate cyclase C receptor agonists, and less so with Plecanatide. And 2.7% of the patients who report diarrhea actually discontinued the treatment. So what you see in a lot of these clinical trials, even though patients will report certain adverse events, usually the minority of them will actually discontinue the treatment because they feel that side effect is not tolerable. So they summarize this as Plecanatide appears to be safe and well tolerated over 1 year. The adverse event profile does not appear to change with chronic use. And if you look at the patient global assessment, it indicates that over 3/4 of the patients were satisfied and they desire to continue with this medication. Then there was this, I thought, very interesting abstract, and it's really looking more at the mechanism of why someone may have constipation and why a guanylate cyclase C agonists would actually help them. So this was entitled Postprandial Pro-Uroguanylin Endocrine Responses Are Attenuated in Patients with CIC, that's chronic idiopathic constipation, and IBS with constipation. Okay, so this is pro-uroguanylin. It's expressed in our small bowel, and it's released when we ingest food. Then through enzymatic processing, it becomes uroguanylin. This is the bioactive form. This is the guanylate cyclase C receptor agonist. This is what binds on those receptors to cause this chloride secretion and sodium and water to follow. You can see the active peptide, but this aspartic acid was exchanged for glutamic acid, and the reason why they did it is it optimized the 3D conformation, so there was greater adherence to the guanylate cyclase C receptor, and that's Plecanatide. So it's an analog of our natural ligand, which is uroguanylin. So these are the downstream effects of uroguanylin. Some of this actually data has been shown in the linaclotide studies, which is another guanylate cyclase C agonist. But it's not a natural ligand, but they work very similarly. But what they do is they activate the guanylate cyclase C receptor, and that increases cyclic GMP. And if you do that, then you will regulate the electrolyte homeostasis by increasing fluid and electrolyte secretion into the lumen, make the stools looser, and then move the stool through the GI tract. The guanylate cyclase, the C GMP will also permeate in the basolateral membrane, and it's thought by animal models, okay, this is not in humans, in animal models, that it reduces the excitation of sensory afferent nerves in the bowel wall, and that's how they think that it reduces pain or abdominal or visceral sensitivity in IBS-C patients. So the aim of this study was to measure and compare pro-uroguanylin and uroguanylin levels in healthy controls, patients with chronic constipation, and IBS with constipation. So they measured pre- and post-prandial circulating levels of pro-uroguanylin and uroguanylin in healthy controls, that's 50 of these patients, or subjects, patients with chronic idiopathic constipation, 53 subjects, and IBS with constipation, 54 subjects. They gave them a standardized meal that you can see here, 750 calories, and then they measured serum levels. And then they measured these hormones by ELISA. So interestingly, you can see that the healthy patients or healthy subject have the open blue circles. The patients are in orange, and then the mean levels are shown in these solid lines. And what you can see is that there's lower preprandial levels in the constipation group, so they combine the CIC and the IBS-C of pro-Uroguanylin compared to healthy individuals. And then after they gave the meal, there was a faster rise in the healthy individuals of this hormone level compared to the constipated group. And this was statistically significant. When they looked at uroguanylin, which is the natural ligand, these levels were decreased in the constipation patients compared to healthy controls, but there wasn't any increase after a meal like you may have suspected, so they interpreted it as that this must reflect the proteolytic maturation at the sites of action rather than that it was actually causing secretion at that moment that they were measuring it. So their conclusion was that there are circulating levels of pro-uroguanylin and uroguanylin that are lower in IBS-C patients and chronic idiopathic patients versus controls. The postprandial endocrine responses of pro-guanylin is slowed in these constipation patients versus controls. It may reflect a paracrine hormone insufficiency of pro-guanylin in the small intestine in patients with chronic constipation. What I thought might be interesting is if you can get these levels at baseline, you don't really have to give them a meal. It would be interesting to determine if you had lower levels, were you the patient that was going to respond to a guanylate cyclase C agonist like Plecanatide or linaclotide? And I thought that would be kind of interesting to see if it was a predictor, because we know not all patients with IBS or chronic constipation respond to any one therapy. So I thought this was an interesting mechanism and one that could even have predictive value. Okay, so I'm going to talk about Kiwifruit, which before, honestly, I went to the DDW, I didn't know. Well, I heard a little bit about it before that I went there. But I'm going to show you there are 5 abstracts. A couple of them are related, and I'm going to show 2 of them and then sum up the other ones. In Asia, they've actually done a couple of, they're not great quality, but they actually have done a couple of Kiwifruit studies and constipation. So with some evidence that it could help patients with constipation. So these series of abstracts study a little further. The first one is by Giovanni Barbara's group in Bologna, Italy. Green kiwifruit compared to Psyllium for the relief of constipation and improving digestive comfort in patients with functional constipation and constipation-predominant irritable bowel syndrome. There were 3 international trial studies. So constipation, as you know, affects 17% and even up to 20% of the world's population. It's a common condition that we all see. Green kiwifruit has been proposed as a natural food remedy for the relief of constipation. So kiwifruit contains 3.4 grams of dietary fiber per 100 grams and is thought to have laxative properties. So I looked up, kiwifruit does taste good. I looked up 1 kiwi, and one kiwi on average is 69 grams. So if you have 2 kiwi fruit, which was the dose in this study, that's like almost 150 grams. So it's about 5 grams of fiber, or maybe a little bit more. Okay, so they did a crossover study. So they had 3 single-blind randomized controlled trials in New Zealand, Italy, and Japan to assess the effect of kiwifruit on symptoms. They all used the same protocol. They had 20 healthy controls, 20 functional constipation patients, and 20 IBS-C. They did a 16-week crossover study. They have a 2-week lead-in to run in to assess their symptoms. They randomize them 4 weeks with 1 intervention, and then a 4-week washout, and then you do the 4-week second intervention and a 2-week follow-up. They used 2 green kiwi fruit a day, I think it was 1 twice a day, versus psyllium, and the amount of psyllium they used was 7.5 grams. They were trying to get it to something comparable to the kiwi fruit fiber. The primary outcome measure, which we see in many constipation studies, is complete spontaneous bowel movement frequency. And their secondary outcomes, they use something called the GSRS. This is a general GI symptom scale. It asks you about really the bothersomeness or the discomfort of various GI symptoms. They also looked at a quality life measure that was disease-specific, so that's the IBS-QOL. They looked at stool consistency, which we use the Bristol Stool Form Scale, and they looked at GI transit time. So this is the data. They had 178 participants, 61 healthy controls, 57 functional constipation, and 60 IBS with constipation. So you can see the data here. baseline is here in the lines. The light gray is Psyllium, this is Kiwifruit, this is washout. Healthy controls, functional constipation, IBS-C, and this is the combined constipation group. This is the number per week of complete spontaneous bowel movements. And Kiwifruit increased the complete spontaneous bowel movement frequency by 2 bowel movements per week for the combined constipation group versus 0.92 with Psyllium after 1 week, and then it remained for the duration of treatment. So here you can see the data. Now, I will tell you, when I looked at this, and you look at the baseline, for complete spontaneous bowel movement per week of having 6 to 7, or down here like 3 to 4, is actually pretty high. Because if you look at any of these phase 3 trials where they're much more stringent on who they enroll, complete spontaneous bowel movements are usually less than 1 per week. They may have somewhere between 2 to 3 spontaneous bowel movements, but most of the bowel movements are not felt associated with complete evacuation sensation. So to me, this meant that this population was probably a little more mild than what you see in a classic phase 3 constipation trial. But it was statistically significant. It was better with the Kiwifruit for their primary endpoint versus the Psyllium. So this was a comparative efficacy trial. If you look at the general GI symptoms, also, which includes abdominal pain and digestion reflux diarrhea, there was significant benefit with Kiwifruit and also with Psyllium. So kind of summarized it here on the additional results. The quality of life scores improved significantly during the Kiwifruit versus the Psyllium, so that was a between group difference that was significant for the constipated group. There was a reduction in straining during defecation. Both the primary and secondary outcome measures returned to baseline once the Kiwi was ceased, which is probably what you expect. So these results suggest non-inferiority of Kiwifruit compared to Psyllium and support first-line use of Kiwifruit as appealing and efficacious alternative to fiber. So I'm going to summarize the several other studies on Kiwifruit that I want to spend a lot of time with. So they did measure colon transit time with Kiwi versus Psyllium, and they found that the colon transit time was accelerated if you measure it 24 hours, 48 hours, and 72 hours with Kiwi versus Psyllium. So it sped transit time with Kiwi more than Psyllium. When they looked at the fecal microbiota, and I can't remember if this was one of the smaller studies, but Kiwi significantly reduced Clostridioideaceae and Streptococcaceae, and increase the levels of Lactospiraceae in IBS-C. So I looked up these bacteria, and these are families, and they're in the genus of Firmicutes. And in IBS trials, they have shown differing results, but in general, they've shown that IBS patients in their fecal microbiota have increased Firmicutes over Bacteroides, and these are all Firmicutes. The Strepto group and also the Lactospiraceae in an IBS trial, these were shown to correlate with methanogen production. So I don't know if that's the reason why these may have worked, but this I thought was kind of interesting that they found some fecal microbiota changes with Kiwi. There was another study that Robin Spiller does, that he did, where he measures he does MRI in these patients, and he looks at small bowel water content, and he looks at colonic distension. He did some nice studies in the FODMAP diet intervention. So he looked at 14 healthy volunteers, so these aren't patients, and he found that Kiwi increased fluid in the ascending colon. It caused dilation, so it brought fluid into the lumen of the bowel, and it accelerated transit. The only thing is that he didn't find that there was a difference between Kiwi and his control, which is maltodextrin, which is a carbohydrate that's in many foods. But I think it's just because the sample size was low. So that's the data on Kiwifruit. So I know a lot of us get constipated if you travel. So if you're at a breakfast buffet, you go to the fruit bar, you might want to load up on the Kiwi, and maybe that'll help people. Okay, so now I want to talk about fecal microbial transplantation because I think that a lot of patients ask us about it. And it hasn't been that much data. There's a lot of ongoing randomized controlled trials, but there were 3 studies that were emerging that they presented at the DDW. So I'm going to start off with showing that there are multiple studies where they compare fecal microbiota, but usually by sequencing, less by metabolites. And they do see differences between IBS and healthy controls, but not in all studies. It's been some confusing data, but the study on the left is from Sweden. The study on the right is actually from our group at UCLA. But basically what both studies found is that if you get the stool from IBS patients and you compare it to healthy controls, you will see a subgroup that looks like healthy controls, and you will see a subgroup that looks different from healthy controls. And then you try to determine what's the phenotype of the group that looks different or looks similar to healthy controls. And often it's something that's more psychological, like more depression or more early life adversity. But it does show that there's increased firmicutes in the IBS patients versus Bacteroides compared to healthy controls. But if you look at the data, to me it's a little bit confusing because there's differences in these different studies. But it looks like a subgroup do have altered fecal microbiome. And that there is some evidence that this plays a role. We also, in IBS, and we also know that probiotics can help in IBS patients, and also rifaximin, and those are all targeting the microbiome as well as the low FODMAP diet. Okay, so there was one published study, our first randomized control trial that was actually published last fall. So I want to go over this before I present you the DDW abstracts. This was in 90 moderate severe IBS with diarrhea or IBS with mixed patients. They used donor stool, that's 60 of them. So they did a 2-to-1 randomization, and the placebo was their own stool. The way they did the fecal transplant is they administered the feces through the colonoscope into the cecum. So they went all the way through the colon. Their primary endpoint was using a validated questionnaire that we use in IBS studies, and that's the IBS-SSS, and that's the IBS Symptom Severity Scale. So the IBS-S can tell you if a patient has really no symptoms, mild, moderate, and severe. So it's a way of categorizing somebody by severity, but you can also look at it as whether they respond to treatment. So usually we use as a minimally clinically important difference of 50 points. They showed us, they used a symptom relief of higher than that of 75 points, and that was a responder. And they looked at patients after 3 months of the FMT. So 65% in the active treatment, that's the donor feces, versus 43% in placebo, which is their own stool, were responders at 3 months, and that was statistically significant. They also looked at the efficacy at 1 year. They wanted to know how well did they do sometime after that. 56% were responders in the active treatment, and 36 were responders with the placebo. And that was a strong trend, but it wasn't statistically significant. As far as adverse events, there was 1 case of nausea and vertigo in the active treatment, and there was 2 with soiling, 1 in each of the 2 groups, and there was 3 with intermittent abdominal pain, 1 in the active group and 2 with placebo. So really wasn't too much difference in adverse events. So this is the one randomized control piece of information we had going into the DDW. So let me show you the data. Now this one was presented at the presidential plenary, and this was entitled Fecal Microbial Transplantation in Irritable Bowel Syndrome with Predominant Bloating. So the aim of this study was to evaluate the effects of FMT in patients with severe abdominal bloating, because as you know, a lot of the microbiome-targeted treatments do help reduce bloating, and we all know that this is a challenging symptom to treat. They wanted to focus on this particular symptom in a placebo-controlled, randomized controlled trial. So they had Rome 3 positive, so they met the Rome criteria for IBS. They were age 18 to 75. They had severe bloating. They used a scale using a symptom diary of 0 to 6 points, and severe bloating was more than 3 on that scale of 0 to 6. Their endpoints was at 12 weeks, and their primary endpoint was self-reported improvement in bloating and overall well-being. So there's 2 different subjective endpoints. The secondary endpoint was the symptom scores, individual symptoms, quality of life, and they also wanted to do some microbiota sequencing. Now, the way they did FMT is they put the stool through the nasojejunal or nasoduodenal administration through the scope. They used 2 different healthy donor fresh stool that served as the donor for all these patients. The placebo was the patient's own frozen stool. Their microbiome was sequenced as 16S using Illumina. Their statistical analysis was pairwise comparisons for group difference and other types of mixed models for the microbiome data. So this is the data. So if you look here, they had 136 patients that were screened. 73 were excluded because they either didn't have a sufficient amount of symptoms, they were IBS with constipation, because they wanted the non-constipated group. It's thought that, I think they were hypothesizing that was the group that was most likely going to respond to FMT and not so much the IBS-C group. And then they didn't want psychic comorbidity. They included 65 subjects. One, there was a technical failure, 64 randomized, 43 to the donor, no dropouts, and 19 to placebo. They ended up having one death later on. So in the placebo group. So this is the data on the primary endpoint. This is the overall symptoms, dark green here in the donor. The placebo was in the light green, and you can see for bloating as well. So about half of the subjects subjectively felt better for their overall symptoms and for their bloating with the fecal transplant gone through the nasal-jejunal nasal duodenal route versus placebo, which was about 30%. So that was statistically significant. Now, when they looked at individual other symptoms, they saw a statistically significant mean reduction in the donor group, the active treatment, but they didn't see that in the placebo. A lot of times when you see these trials, you see a within-group difference with the active treatment and less of a within-group difference in the placebo group. But you don't necessarily see a between group. And what you're really looking for when you look at a clinical trial, is there a between group difference? But what they found, and you can see the percentages because I had it here for you, these discomfort, number of stools, urgency, abdominal pain, flatulence. There was some benefit in the active treatment that was statistically significant, but they didn't see with placebo. They found that the disease-specific quality of life measure was improved in the donor group of 16%, which was statistically significant, but not in the placebo group. They looked at the patients at 1 year, 27% were still improved, so a quarter of them, and 73% relapse. And that's probably not that surprising. When you do one intervention, your microbiome could eventually go back to its usual state again. These aren't great graphs. I try to get it from their poster, so I'm sorry about the resolution. But they did a supervised plot and also a supervised one. And basically, they were trying to make the point that if you look at the active treatment, which is in red, versus the placebo, you do see separation of the microbiome in the groups, and that if you really can look carefully, the patients who got the FMT that was active, but they were unsuccessful, their microbiome looked more like the patients who got the placebo stool. So they think that there was some association that you did alter the microbiome with the FMT, and that the microbiome pattern in the successful FMT looked different than the unsuccessful and the placebo group. So they concluded that FMT with fresh donor stool was efficacious in relieving IBS symptoms and bloating. About 25% had a long-term effect at 1 year. FMT was associated with significant changes in the gut microbiota, which are related to treatment success, and the non-responders looked closer to the placebo than responders to the donor FMT. I'm going to show you another one as well. So this is FMT alters gut microbiota in patients with IBS. This results from a randomized double-blind placebo-controlled study. Okay, so this was a little bit different. Their aim was to perform a randomized double-blind placebo-controlled trial to investigate if FMT resulted in altered gut microbiota and improvement in clinical outcomes in IBS patients. They had 52 adults, so these aren't large studies. They had 52 adults with IBS. They used, again, moderate to severe disease activity, and they randomized them to FMT or placebo. But they did is they used capsules. Okay, so it wasn't stool through a colonoscope or through an upper endoscope. And they did this for 12 days, and they followed them for 6 months. They collected stool at baseline, day 15, 1 month, 3 month, and 6 month. So patients with FMT capsules had an increase in biodiversity. We all know that health is associated with greater diversity of their microbiome compared to disease. It's not only specific to IBS, it's seen in IBD and other diseases. And they were similar to donors. The placebo patients remained indistinguishable from pre-treatment state. There were no significant differences in IBSSS, so they didn't see a symptom difference with these capsules for FMT at 3 months after treatment. The IBS quality of life measures showed a significant difference in improvement between FMT and placebo at 3 months, favoring the placebo. So the placebo group actually had a better quality of life than the ones who got FMT with the capsules. So their conclusion was FMT changed the gut microbiome. They saw that. But the patients in the placebo group experienced greater symptom relief than the FMT. So that showed you that even though you altered the gut microbiota, it wasn't enough to obtain symptom relief. So there wasn't really that correlation. However, they recognize that different study designs or larger studies are required to examine the role of FMT. That's what I actually thought. Okay, and the last one that I was going to bring for FMT was a double-blind, randomized, placebo-controlled trial of fecal microbiota transplantation. These are capsules, again, for the treatment of diarrhea-predominant IBS patients. So their aim was, again, to look at FMT in a randomized controlled trial. They had IBS subjects, again, moderate severe patients, but these all had IBS with diarrhea, and they randomized them 1-to-1, not 2-to-1, for 3 consecutive days, so shorter duration of these capsules, with the donor stool versus placebo capsules, and they looked at them for 12 weeks, and then they switched them to the other treatment for 12 weeks. So this is a crossover. Primary outcome was a decrease in the IBS-SS. As I said before, 50%, it was what you're looking for a minimally clinically important difference at 12 weeks. They also had these secondary outcomes of IBS-QOL, again, hospital anxiety and depression. This is a scale we use very often. It's current anxiety and depression symptoms. It's not diagnosing depression or anxiety by the DSM-5 criteria. It's just giving you an idea of your current anxiety and depression symptoms, and they looked at Bristol's stool form scale. So they looked at pre- and post-interventional stool samples for the 16S microbiome analysis. So each group had significant improvement in these different outcomes, these symptom outcomes, the severity, quality of life, the Bristol stool form scale between baseline and 12 weeks. The clinical response was similar between the FMT and the placebo group at 12 weeks. So you can see it wasn't statistically different. There was no group difference. So there was no between-group difference, okay, by IBS-QOL, the hospital anxiety and depression scale, or the stool form. The subgroup analysis showed that the post-infection IBS, so that's the subgroup of IBS patients who don't have pre-existing IBS symptoms. They get a GI infection, the infection clears, and now they have IBS symptoms that are sustained. That's called post-infection IBS. That makes up about 10% of all the IBS that we see. They looked at that one subgroup, and of course this is a small number of patients, and they saw a strong trend for improvement of the overall IBS symptoms at 12 weeks versus the placebo. And the preliminary microbiome analysis in a quarter of the subjects showed a trend for differences in the FMT responders versus non-responders. Sorry, I wasn't able to get actually figures from their presentation. So I know this is preliminary. The conclusion was FMT did not induce significant symptom relief at 12 weeks compared to placebo. The subgroup analysis suggested that it could be more efficacious in the subgroup of post-infection IBS. So I try to summarize all of these randomized clinical trials for you, and also the published study. This is a limited number of studies with small sample sizes. And as you know, IBS is a heterogeneous condition. If you do a phase 3 trial, you need 600 patients, 1,000. So you have to recognize that if you're using 50 patients, you either have to try to recruit them in a very homogeneous population, or you're going to have some differences. So that's why you usually have to study a larger group. So that's just a limitation to think about. They studied predominantly non-constipated IBS with at least moderate severity. The nasoduodenal jejunal route and the colonoscopic administration route, to me, based on the published study and based on that first abstract I showed you, looks to have greater efficacy with FMT, than with FMT given by capsules. There was a significant effect on overall IBS symptoms and bloating. A subset have sustained symptom relief at 1 year. That was about 25%. The FMT was associated with gut microbiota changes, but that didn't necessarily correlate with a symptom improvement. And adverse events were similar between groups. And multiple ongoing studies, I want you to know, they're happening, and so we will wait for these larger studies to really determine if IBS can benefit from FMT, which route, how do you administer, which particular patients. We'll have to get that information with more studies and higher quality studies. So I guess I ended early. I thought that I was going to run out of time, and I should have talked about other things, but thank you very much for your attention.